how is health between Kenya, Canada? Like how our health systems, I am sure our health
Uh,
systems are here.
now, Jackie, I think that's just a topic for another day because sijui nianzie wapi. Sijui
Eh,
nianzie wapi. All I can say is, unfortunately, Kenyans, we are on our own. That's just the thing I can say. Like, in a nutshell, in Kenya,
yeah.
if you don't have money, you're on your own. Period. That's it. That's just it. If you don't have a good insurance, if you don't know somebody who knows somebody who can get you to India or whatever, you're done. And it really breaks my heart because I have worked in Turkana. I have worked, like me. I'm talking because I feel like I can talk because I have worked in the public sector. I've worked in the
Yeah.
faith-based sector. I've worked in the government, in the private sector in Kenya. So I know deeply how each and every part of the system works there.
Yeah.
And the truth is, if you don't have money, pole in Kenya. That's just it. Whereas here, I airlift patients, airlift for free, Jackie. Right now, you
What?
attack, yeah, I approve. You get airlifted, you go get your treatment, pay 0 shillings, leave the hospital, move on with life. They don't care if you're a street child, if you are some farmer from the village, or the president or the prime minister, you get the same care. That now you
What?
tell me, you seeing the difference? Like,
That's
it's
an
nice.
extreme
I
difference.
cannot. When I first came here and patients were being discharged from ICU, and I'm not seeing anybody come to cry to me or come to ask for money, michango, or whatever, it was a culture shock by itself. I was like, how do you just walk out of ICU? Like, oh, you're done. Go take your meds and you're done. I was like, it was a shock. But
Mm.
yeah, we have to improve the systems in Kenya. We have to get better leaders. Like, it's a matter of urgency. We can't keep on just saying, oh, the reason why you're on your own is because the government is not working for you despite you paying the taxes, which means we need to get a better leadership. That's it. It's a leadership problem, in my opinion.
No, I don't think it's just in your opinion. We all know we have a leadership problem, and we just keep singing the same song
Yeah.
over and over and over again, and just keep shifting names from one name to another, calling it something else, but then the underlying problem is still the
It's
same.
the same.
And
It's
it
the
just and unfortunately it's just going to get worse because
same.
disease is not stagnating and saying, okay, you guys don't have a healthcare system, you guys don't have proper insurance, you guys don't have money, so let
So
me
let
first
me
take.
let me have you seen the slide, Jackie, for the growth of diabetes, like projected growth in different continents? I wish I had that slide. The projected growth of diabetes in America or in Canada, where I am, is 24% by 2045, which is not bad.
Yeah,
The
it's not so
projected
bad.
growth of diabetes in Africa is 183%. 183%.
What?
Yes. Na saa hizo, there's no 183% increase in cath labs, in dialysis units, we are not ready to deal with the complications. And that's why, Jackie, we have to preach control. We have to preach preventative. Do
Yeah.
as much as you can what is in your control, because if you leave it at the system will take care of, there's no system to take care of it. Whatever you can take care of yourself, do as much as you can. That's why I like your approach of telling the patient, you know what, the power is in your hands. For most cases, of course, there are some cases which are unique. You have patients, for example, who have familial hypercholesterolemia, their cholesterols are through the roof, they get atherosclerosis. There's always outliers, but for the majority of patients who have type 2 diabetes or hypertension, as
Yeah.
long as they're able to get the control, they will at least avoid the complications, majority of them. So
That's
that's why
very
we keep on preaching that prevention and then screening for complications early, because we don't have the capacity to deal with the complications the way here in Canada they would. So yeah.
You see that statement you made? I think you should just put people in shock mode. We do not have the capacity to
We
deal with
don't.
complications.
We
Full
don't.
stop. Yes.
We don't. It's a joke. It's a serious joke. You know, and then I think when you come out here and you see the way they deal with complications, let me tell, even like my patients who have diabetes, when I look
Yeah.
at their past medical history of lung cancer in 2005, history of breast cancer to 2010, history of whatever. And I'm not saying that we don't have, like, what I'm trying to say is I didn't see as many people who had a history of cancer in Kenya because most of them die. Most of them die. Like, how many patients have you clocked and you're like, oh, you had a lung cancer in 2010, pneumonectomy, now you're cancer free. Ah, okay.
Yeah.
How many exactly? How many? That by itself was a shocker to me because I realized that we are living very different lives.
Yeah.
The difference is so stark. And again, it
Mhm.
goes back to what we can get in our country. In Kenya, we still have a lot of systems to set up. Our cancer is diagnosed too late. People don't like to go for screening, or maybe they don't have access to screening. There are many things that just make it harder, I guess, for people to be diagnosed earlier in the third world countries, not just Kenya, in literally all
Yeah.
the countries. Yeah.
And in light of what you're saying, I think one of the biggest problems we are now experiencing is behavioral change,
Mm.
where there's this policy we have as Kenyans where we say, what you don't know doesn't kill you. Where do I want to go and get
Yes.
checked or I'm taking it fair. What will happen? And
That is so
that's
true.
what, one of the reasons why people don't go for screening,
Mm.
because they're like, "Hii inaangalia nini? Inaangalia cancer fulani. Alafu mkipata mtafanya nini?" And then now you explain. Then they're like, ni sawa tu, nitakuja siku ingine.
Siku
That
ingine,
person will
which
not
never
come.
comes, which doesn't
Yes.
come.
But in the light of also making them not feel like it's always their fault, despite our behavior issues, sometimes I think our failed healthcare system also makes people scared because people are like, you'll be found with something, you have no finances to deal with it,
Mm.
niitishe harambe, niitishe mchango, all those things to be able to support
Yeah.
your health because you can't afford. And you know, these days, that's how people are actually surviving.
Mm.
Your healthcare system is free, whereas here you have our healthcare system is basically out of pocket. We may see here how we have SHIFSHA and HIF, etc., etc. It's still out of pocket. We pay a lot of money. Even for that private insurance, you put a lot of premium into it for you to be able to be taken care of. And mind you, if you get a chronic a condition or you're predisposed to one, your premiums now change. I've always wondered why not go into the spectrum of the space of preventative healthcare and wellness. And maybe we even give people coupons or just something, incentives to make them actually move towards the preventative side. So you're told for every wellness check that you do and they don't find anything, maybe we'll pay your rent for like 1 month. Okay, I'm just joking, but it's an incentive
Mm.
that pushes you towards taking care of your health better.
Mm.
Because
Yeah.
there's a story, and other than behavioral change in our healthcare system, there's a story I was listening to yesterday,
Mm.
and it is in the context of Mandela. And now this brings in the concept of where you are versed in diabetes, hypertension, chronic diseases. So in Northeastern, we have ladies who are taking steroids. And do you know how many pills they are taking in a day? About 18, they mentioned 18 to 21 pills in a day. Do you know it is for what reason? So that they can
Like,
get what is that face called?
oh, the Cushingoid nini face. The
Yes.
nini. Oh my
Yes.
gosh. Are you
They can get
serious?
the face, they can plump up, they can,
Are you
become
serious?
rounder and all that. They can have the hump because it is being
They
looked
want the
at
ham. Who
the
wants a
beautiful,
ham?
like you look beautifuler and all that. And they are also adding now the creams on top.
To
So
light the hair.
now, exactly, you're round and lighter.
Oh my.
Imagine the kind of complications that they're coming up with. It was a podcast I was listening to of some doctors who are in Northeastern who've been doing a certain podcast, which is very interesting. And now they were discussing about how that doing of the steroids is
Mm,
coming up with now complications of diabetes,
mm.
hypertension,
Yeah,
you name it.
yeah.
You know,
Even adrenal insufficiency, yeah, because at some point they might not take steroids for some time, and boom, your adrenals just they go to
exactly.
yeah.
And you
Wow.
can imagine the kind of work it will be to even wean off that person out of 18 to 21.
I cannot even. That is such a huge dose. Oh my goodness.
Exactly. And now you must now that's a new problem that we did not have that has started developing on that part of the country, right? And you
Wow.
see now people don't know. People you know, sometimes as human beings we don't know. Even as the healthcare worker, you'll be knowing if I take this route, this is wrong, this is correct, this is okay,
Mm.
this is bad. They don't know. Them they're looking at it from that perspective. But then they end up complicated and in the hospital. Now all these things come up. Do you type one, do you type two, do you what all those things? Something you didn't have, now you have it. But all in the name of looking beautiful and satisfying societal norms and standards
Mm.
at the expense of your health. Yeah.
Wow.
This is now you see every single day. So you're saying our healthcare systems are just off. Every single day we have something new that has to be discussed. Now this is a whole new fresh,
I,
right?
like I can't even believe it.
Exactly.
That means that there's a pharmacy somewhere that knows better, but is just dishing out these because they're not getting these medications from nowhere, right? So there's a probably either a pharmacist somewhere or a doctor somewhere giving out these medications. They're not just
Exactly.
getting them from nowhere, which again means there's a problem with the healthcare system because who is this who is doing this?
Yes.
Lack of oversight.
Yeah. These days you find how many chemists and all these things are run by people who didn't even go to any form of
Yeah,
school.
yeah.
Am-
Or
Amefungwa hiyo kitu
parallel
mpaka
imports.
biashara.
Yeah. Or parallel imports. People are just bringing, some people bring drugs straight from street. They smuggle them in. So
Yes.
they can't be accountable to really anyone because they're just doing their own thing. Nobody even knows they have the drugs. Oh my goodness, that's just wrong.